Okay, sir. We are live.
Good evening, everybody. On behalf of the Rezūm Urological Society of India, I welcome all the postgraduate students for this second session on benign enlargement of prostate. I hope you had a lovely first session and be ready to enjoy the further sessions that are going to come up almost every month as the schedule will be posted over the period of time by Dr. Rajesh, our secretary. With these viewers, and I think without wasting much time, I would like to congratulate all the eminent faculty. We have senior faculty for all of you today who have tons of experience with them, and hope you make the best of this opportunity. We had a very good last session with good attendance, and I wish you all the very best. I thank the council once again for this ardent effort that they have done to get this webinar up, especially our council member, Dr. Vilas Sabir, and today's convener, Dr. Subodh Shibir. With these few words, I hand over the session to Dr. Vilas Sabir to hand it over to Dr. Shibir. Thank you so much.
The YouTube hasn't started as yet.
Oh, has it?
Sir, it has started, sir.
It has started. Now, yeah. Now, yes.
We can proceed, sir. We can proceed, sir.
Yeah. Dr. Ashish Patil.
Yes.
Just as a presidential remark, please repeat your remark.
No, sir. It is already there, sir. We can proceed with the program, sir.
Okay.
Okay. Over to you.
So, good evening, everyone. I thank West Zone Council, our President, Secretary, and our colleagues for giving us this opportunity. And this is the second part of the BPH webinar, Navigating through BPH. Today, you must have gone through the list of speakers. All of them are stalwarts in urology. And we are lucky to have such a well-established senior urologists who are experts in different technology being used for prostate. And we have really tried to approach the bosses and the expert panel, Dr. Pankaj Maheshwari, Dr. Ajay Bhandarkar. Both of them are very well known for their work in lasers. We will start with the first lecture, that is from Dr. Deepak Kirpekar, sir. I'll just take a brief opportunity to introduce Kirpekar, sir. Kirpekar, sir, is well known to West Zone. He had been West Zone president and then USI president. Besides, he has been member of variety of organizations, including Association of Surgeons of India, Association of USI, then member of American Urological Association, World Endourological Society, SIU. Then he has been visiting professor at multiple places in United Kingdom, USA, and some part in Gulf. He has a significant scientific contribution, more than 25 presentations, 150 times he was invited guest. He has done 66 live operative workshops, 3 book chapters. He was a teacher for DNB at Ratna for many years and HOD at the Ratna Hospital. And there are 32 students passed from him. The best part is he has delivered an oration on prostate, especially TURP, and he is non-arguably one of the best resectionists in India. He has more than 16,000 TURPs done as of now, about 1,200 renal transplants, about 3,000 PCNL, 4 to 5,000 ureteroscopies, and so more, and multiple. He has been one of the initial pioneers in studying holmium laser. He has delivered a Himadri Sarkar oration in 2016. He has received a Know Your Guru award in our last West Zone at Indore. And he was a President Urological Society 2014-2015. And he has organized variety of conferences, workshops in Pune and has been part as a exception as a panelist and operating surgeons in variety of live operative workshops. So over to sir.
Thank you, Vilas. Thank you so much for such a elaborate introduction. Are my slides seen?
Yes, sir.
Right. First of all, it's a pleasure and honor to be the first speaker for today's session, and I would like to thank West Zone Council for this opportunity. Why is it not moving?
Sir, you can take your mouse to
Yeah.
the...
Okay. One surgery that separated urology from general surgery was monopolar transurethral resection of prostate, and that's 85 years ago. Even in 2025, every resident wants to learn this technique and want to master it. Before I actually go on to discussing the transurethral resection of a prostate, all my speakers who are following me are going to use the same route. And so I thought I'm going to request 2 extra minutes to go to the history of transurethral resection of prostate. Hampton U. Young, Peter Freyer, and Terence Mellins, all of them found a relative avascular plane by different routes around the adenoma. But those were the days mortality was very high and somebody had to think out of the box. Robert Nitz in 1887 constructed the first cystoscope. McCarthy had a 4-oblique telescope in 1923. Stern was the first person in New York who actually used the tungsten loop controlled by a ratchet to cut the tissue of the prostate. This was modified by McCarthy in 1931, and then actually the technique was developed by 1938 by Nesbitt. The breakthrough was Sir Harold Hopkins, who invented rodlet system, and that changed entire endourological vision, and we are all aware of it. To put it into nutshell, 4 different inventions at 4 different times. Incandescent lamp, Edison, 1879. High frequency current, Hertz, 1888. Fenestrated tube, Hugh Hampton Young, 1909. And tungsten wire, Stern, 26. This was all brought together by McCarthy, and that was the birth of a transurethral resection of prostate. Nesbitt was responsible for the technique part of it. It took 20 years after that to improvise. Better image due to rod lengths, better light due to fiber optics, better diathermies. And then in 1960, it got accepted as a standard of care for prostatic enlargement. I'm not going to talk about symptoms. I'm just going to talk about one patient who is a 70-year-old male, 50 cc gland, residue, obstructed flow, normal PSA, failed medical treatment. If you give him an option today, he has plenty to choose from. The latest entrance are steam and compression, but he is looking at a genuine, sensible urologist to give him advice. Reisweiler did a Medline search 79 to 2005 and reviewed it in 2019. And you can see hardly there are any complications related to this procedure, in spite of the fact that thousands and thousands urologists do it. The need of the day is to avoid stricture and preserve ejaculation, maintaining all the benefits of good resection. I'm going to actually start off with this because everybody is going to do this as a first step. Assessment of the urethra, look for BXO, look for fibrous rings, look for tightness of the urethra as compared to your scope, and look for any existing strictures. When it comes to assessment of the prostate, middle lobe associated with ureteric orifice and apex of the prostate in relation to the sphincter and in relation to the verumontanum. I'm going to just show you one clip of a prostate. Everybody who is watching this is a good resectionist, I know. All of you know how to do a good job. I'm just going to show you a 60-gram prostate with the middle lobe, lateral lobes kissing, elongated prostate, which is obstructive, going beyond the verumontanum, and that's where the sphincter is. As far as I'm concerned, If I can reach the bladder comfortably without folding the penis, I can do a resection. The trick is to use the full depth and the length of your loop to minimize the time. As you keep on doing it, keep on superficially coagulating, because vision is the most important part as far as this surgery is concerned. You've got to see a clear vision. When it comes to a large middle lobe, I like to flatten the middle lobe, not resect the middle lobe to its capsule level, just flatten the middle lobe, because it allows a good water flow. The chipped in pieces of the prostate fly back into the bladder very comfortably, and that's how you can increase the speed. Once you have used the full thickness or depth and the length of a loop, then you can start using the length movement of a resectoscope as well. This only comes with expertise, but that's the way you can save on time, and that's the way you can do large resections very quickly. Now you take a booklet and use the scope, move the scope forward so that you can come to the desired level of resection. Having resected the middle, flattened the middle lobe, I have not resected it, flattened it. My next aim is to go to 1 o'clock and 11 o'clock to get the flocks. These are the two arteries which are consistently present in everybody. And if you control them at that level, it may not be in one sweep that you control them. You have to control them at the capsular level, because they will keep on otherwise appearing again and again. Once this is done, you drop the lateral lobes in the center and start resecting it to the lateral extent. Identification of bladder neck, identification of a sphincter are the two most important criteria. I'm going to go a little forward here and say, with the new cameras that we have, tissue differentiation is also very nice. So you are safe in understanding the quality of a tissue, and you can resect. This is sphincter. Apical lobes also have been resected. And once you've done a basic resection, then you start giving a depth to the tissue. And the depth of the tissue is identified by tissue texture. There are two things which are very, very important with flocks. Is don't worry about the spurters. They are very, very superficial, and they will appear again and again, but control them at the level of the capsule, and then the rest of the resection becomes much simpler. These are the two dreaded situations that I want to talk about: a sinus bleeding and a capsular perforation. Intermittently put your inlet of water off so that you can see if you have caused the damage, because this will not appear as long as your flow is flowing in. Your flow should not be under high pressure. Your flow should be 60 centimeters above the patient. Other slide you can see, when your coagulating current shows a capsular contraction, don't use cutting current in such areas, because this is going to immediately cause a perforation. As regards sinus bleed, you can try various manuals. You sometimes feel it has stopped. It feels good, but it never stops so easily. Here you can see cutting current has actually produced a huge perforation in the capsule. Luckily, these accidents happen at the end of the surgery. Be quick, evacuate the pieces from the bladder, put a catheter, and use a traction. And they should be able to manage with a good traction for 12 hours. People are always scared of apical lobes. Again, with good cameras, differentiation makes it very simple. You can see the capsule below. You can see the adenomatous tissue, glandular tissue there, and you can resect, irrespective where the value is. As long as you can see the glandular tissue that you are resecting, it is safe to resect beyond Veru. So ultimately, TUR syndrome today is non-existent. Post-TURP strictures can be avoided. Recurrence is only inadequate resection. Erectile dysfunction is something that has to be assessed preoperatively. Loss of ejaculation, we are not assuring anybody yet. Coming back to the first side, assessment of the urethra is very important, and any place where you find a ring or a tightness, use full-length Otis urethrotomy, and that will definitely prevent a stricture formation. Plenty of lubrication, intermittent lubrication, and being in the urethra for a short time is very, very important. Erectile dysfunction has to be assessed preoperatively so that you can actually come up with the figure. The figure is 9%. This is a massive study of 20,000 patients, and a reoperate for TURP was absolute risk at 15 years was 6.6%, whereas for open prostate, 3.3%. So is a translator resection adequate or complete? According to me, a well-done resection is complete. Unfortunately, all the new modalities don't have such a long history of technique, and that's why we cannot compare them at the moment. This is ejaculation sparing resection. If you look at the zonal anatomy, the central gland encapsulates the ejaculatory duct. So if you spare supra and paracalcular tissue and do the good resection, otherwise there is the 80% chance that this person will have preserved ejaculation. Do it, note it on the discharge card, and ask him the question after 6 months. I'm just going to run through one quick slide where this is a resected fossa. This is an art. The more you do it, you will get better at it. I do not stop 75 ecosprin before resection. It is quite okay to go ahead and do it. Just remember, no resection should be done with a hypotensive anesthesia. This is sparing, ejaculation sparing resection done. There is a good space on either side of a verumontanum and supracalcular, and he will have a spared ejaculation. Otherwise, you can see the capsule exposed everywhere else. This is a report that came up by Urology Gold Journal in 2021. The blue is transurethral resection. All over the world, it is still practiced. Majority type, newer methods have come up and have declined. TUL has started declining, and the rest of the things. I'm most surprised in this that the HoLEP has disappeared in 2021. I think that must be a mistake, because HoLEP also is a wonderful procedure. If you have a resection as deep as this, as wide as this patient will always thank you rest of your life. There are three things to remember. What matters for a majority of patients is availability, accessibility, affordability, accountability, and assurance for long-lasting results, which in the present era, TURP offers. Thank you very much.
Thank you,
Thank
sir.
you, sir. Thank you very much.
It was a fantastic presentation and excellent videos. So it will give insight to many students how to go ahead with TURPs and how to identify the tissue. Now, over to Subodh.
Sir, by the time Subodh sir is live, can I ask you one question on behalf of few residents, sir?
Yes, please.
Yeah, sir, there is, an old teaching that, previously we got two systems. One is a rotating system and one is non-rotating system, sir. So what impact does it have if you use a rotating inner sheath and a non-rotating inner sheath? What impact it does have on the post-TURP stricture, sir?
Now, there were cameras which were designed to hang perpendicularly down so that the surgeon doesn't have to hold the camera. And it, by weight, sheer weight, they were hanging down, keeping the vision 12-12 and 6-6. Unfortunately, those cameras are very difficult to handle, and all of us use left hand on the camera and orient ourselves. If we do that, then non-rotating system is the best system to use. Rotating causes confusion. If the camera is by weight hanging down, then rotating should be okay. But since all of us use the left hand to hold the camera and the right hand to do the resection, a non-rotating resectoscope is my favorite.
Okay. Subodh sir.
Subodh has some problem with his connection. Now we'll be proceeding to the next speaker, Dr. Sadashiv Bhole. He is going to talk on holmium laser enucleation. He was one of the early pioneers who has established low wattage holmium laser enucleation. And
Vilas Sadashiv
we
is
were,
not there in the Zoom.
oh, Sadasiv hasn't joined
Sadashiv
yet.
hasn't joined. Yeah.
Yeah. So we'll till then we'll move on to Dr. Ketan Vartak. Dr. Ketan Vartak. Dr. Ketan Vartak is a senior urologist. He is a professor at Bharati Vidyapit, Pune, in the Department of Urology, and he is one of the national international master on Thulium YAG laser prostate enucleation. So over to Ketan.
Thank you, Vilas. I'll just share my screen.
Hello. Yeah, looks like I'm back as far as the sound is concerned. Vilas, can you proceed, please?
Yeah.
Thank you.
Subodh.
Yeah.
Dr. Sadashiv hasn't joined as yet. So till then we are going to Ketan. Ketan is
Sure.
starting his presentation.
No problem. Thank you. Sorry about the glitch.
Yeah, so good evening, everybody. I'm here to talk on thulium laser enucleation of prostate. And since this is the main impetus is on the teaching for the residents, I won't go for the videos and the technical details of thulium laser enucleation. Rather, I'll clear the minds of what the confusions created between the various laser modalities and energies. So we have multiple energies with us for a good prostatectomy. So what does the urologist want from the energy to give it to him? One is that it should be a very, very fast and effective cutting, as well as coagulation, as well as vaporization. It should be versatile enough so that one can shift from vaporization to enucleation and vice versa, and different combinations of all these techniques. It should fit for all sizes of the prostate, right from 25 grams to 250, 350 gram prostates. Now, doing only prostatectomy, as Dr. Kirpekar sir said, doing only prostatectomy these days is not good enough. We should give additional benefit to the patient in respect to maintaining the erectile function as well as the antegrade ejaculation. Now, many patients are coming on antiplatelet agents and anticoagulants, and that energy should help us in achieving a safe outcome regarding the prostatectomy. The less catheterization time and less admission time and less morbidity will add to whatever surgery you are doing to the patient. And we are coming across a lot of patients with multiple comorbidities. So these are the high-risk patients where your energy should be safe and effective for the outcome. Now, as I said, there's a lot of confusion. Whenever I talk to the residents and the younger urologists, they have a lot of their mind is confused about various lasers, and especially thulium YAG laser and thulium fiber laser. So I will just try to alleviate all those confusions in their minds. So if you see the interior of the thulium YAG laser, this is the diode pump. This is a schematic diagram. This is the actual photograph of inside of the laser. So this is a diode pump which gives rise to the energy. It passes through the diode, passes through the thulium YAG crystal or the thulium tube, what is called as. And then the energy will be collimated, and through the mirrors, it will be given to the fiber, and that's how the energy goes. Now, mind you, this is the thulium YAG laser is a big machine with the size of almost like a refrigerator, and it creates a lot of heat, so it requires a lot of cooling machinery. So the chillers are there, especially thulium YAG lasers have two chillers, chiller 1 and chiller 2, for the different components of thulium laser. So these are big machines. Compared to this, if you see this is the typical thulium fiber laser, which is normally a tabletop machine. It doesn't require any cooling. If you see this is a fan cooling, that is called the air cooling. It's a very simple, it doesn't generate any heat. The technique is that the diode pump is there. The diode will create that energy. And instead of the thulium crystal tube, it will have this thulium doped fiber. Okay, so thulium doped fiber, the energy passes through this fiber and create that thulium fiber energy, and it will pass through this localizing beam, and it will be giving the energy to the fiber. So the simple thing is that it has no rod lenses, no flash lamps, and no chillers. Okay, so this is a very simple tabletop machine. So this is the main difference between the looks of the two lasers. Now, what are the most important characteristics of the laser on which you select your laser? The most important is whether the energy is pulsed or a continuous wave. Now, it should be very, very clear in our minds that by nature, holmium laser and thulium fiber laser are pulsed in nature. Whereas by nature, thulium YAG laser is a continuous wave laser. Okay. Now, if you see the firing of thulium fiber laser, especially in high frequency, like you are dusting a stone, it appears that you are in a continuous mode, but it's not a continuous mode. It's a pulse mode with a very, very high frequency. So the thulium fiber laser will always have the energy, the wattage, as well as the frequency. Holmium laser, as we all know, it is purely a pulse wave energy and not a continuous wave energy. Now, if you come to thulium YAG laser, by nature, it's a continuous wave energy, but newer machines will have a foot switch or the setting which will give rise to pulse wave energy. But the difference is that by nature, it is a continuous wave energy. By shuttering of the lenses, so they shut off the energy and create that pulse wave appearance. It is not a pulse wave energy. That's why it is not useful in stone disease. So thulium YAG laser is not useful in stone disease because it's a continuous wave energy, whereas these two are useful in stone disease because they are a pulse wave energy. Second most important thing is the pulse peak, the peak pulse energy. I'll come to this in the details in the next slide. Third thing, most important is depth of penetration. Now, if you are giving rise to, I mean, we are offering the prostatectomy to a younger patient and we want erectile dysfunction and the retrogradulation to be maintained, then depth of penetration is very important because more the depth, more are the nervi regions getting damaged. At the same time, more the depth, more is the damage to the capsule and the pericapsular area. So that's why depth of penetration is important. And the last is absorption into water, absorption of the laser energy into water and absorption of laser energy into the blood. I'll come into these two criteria in the detail later on. Now, this is the most important. I've been looking for this at this slide for a very long time, but I never understood this for a long time. But nowadays, I'm getting a grasp of it. This is the thulium working area. This is the thulium working area. This is the holmium working area. This is the thulium working area. Now, if you see this, if you set your holmium laser to a high power energy power setting, then the peak pulse power that you get is 10 kilowatt or 10,000 watt. Okay. If you set it at a low energy, for example, while dusting, it will create a peak power of 2,000 watt or a 2 kilowatt. But if you see the thulium fiber laser, the maximum peak power that it can achieve is 0.5 kilowatt or 500 watt. And the maximum peak power of thulium YAG energy is 0.2 kilowatt or a 200 watt. Okay, so how does it matter? The energy delivered at the site, the holmium laser is giving such high peak power, and that's why it is creating that hammering effect. Whereas in thulium laser and thulium YAG laser and fiber laser, because the peak power is less, that's why it is giving less hammering effect. So if you see the dusting effect of thulium fiber laser compared to a holmium laser, the stone will not move at all in thulium fiber laser, but it will keep on moving here and there in a holmium laser because of that peak pulse. You can reduce it by minimizing the energy, but you cannot avoid it fully. So that's how the difference between the pulse energy and a peak power, peak pulse power of the various laser energies. Now, how does the depth of penetration in the tissue matter? If you see this, I'll just shift this. Just once. Okay. If you see this, the depth of penetration into tissue of thulium fiber laser is 100 to 150 micron. That is 0.1 to 0.15 millimeters. It is absorbed twice into water as compared to thulium YAG laser. So that's why it penetrates less into the tissue. It is more superficial in nature, but that's why it is less coagulative and poor in vaporization. It's a simple thing. Your depth of penetration is only 0.1 millimeter. So vaporization is very, very poor. At the same time, the depth is so poor that the vessel to be coagulated is not getting damaged enough, so that the coagulation is poorer as compared to a thulium YAG laser. You understand? Now, coming to thulium YAG laser, the depth of penetration is 0.15 to 0.25 millimeter or 150 to 250 microns. It is well absorbed in water as well as blood. So it is ideal in cutting as well as coagulation as well as vaporization. How does it achieve this? If there is a blooding vessel, the vessel is made of tissue. The tissue is made of 80 to 90% of water, and there is a blood flowing into the vessel. So whenever you give the energy, especially thulium YAG energy, because it is absorbed in water, it will create a lot of damage to the vessel wall, and that's why the vessel wall gets crumpled. At the same time, because it is absorbed well in blood, the blood cells will get damaged. It will form a coagulum, and the vessel will be sealed. So the effect on the vessel from outside as well as inside is very important in achieving the good hemostasis. That's why if you compare thulium YAG laser to any other laser or thulium YAG laser to any other energy, thulium YAG laser primarily seals off majority of the vessels while it cuts. So 80 to 90% of the vessels are getting cut at the time of enucleation itself. The rest of the vessels, whenever the bleeding vessel is there, then you can just pinpoint at the low power, and so that it will achieve the good coagulation. Now, if you compare this to holmium laser, it will give the depth of penetration to 400 microns, that is 0.4 millimeters. But the inherent pulse nature creates an avalanche of photons, photon bubbles, which are creating micro explosion between the capsule and adenoma. So if you see the technique of enucleation in holmium laser, you just keep on firing that laser at a particular frequency between the capsule and adenoma. It will keep on dissecting the lobe from the capsule. It is a dissecting kind of laser because it will create micro explosion between the capsule and the adenoma, and that is how the enucleation is getting done. Whereas in thulium and thulium fiber laser, it is a cutting energy. So you're cutting across the plane between the capsule and the adenoma, and you're achieving the same goal. That is good for this micro explosions, or the photon bubbles are good for stone disease because it will create a good fragmentation. But whenever you are firing the same full energy on a bleeding vessel, then the same effect will appear, and the bleeding vessel will keep on moving here and there. The damage to the blood vessel will be less, and the coagulation will be poorer. So if you see the primary hemostatic properties of a thulium YAG laser, they are the best. Now, if you compare this to depth of penetration to your patients on younger patients, say suppose they're coming for enucleation, then the depth of penetration will damage the nerves which are just posterior to the capsule less, and that's why the erectile function will be maintained properly as compared to the laser which have more depth of penetration, or especially cautery. Electrocautery will have a depth of penetration in few millimeters, not in micromillimeters, but few millimeters. So the damage to the nerve is much higher in a electrocautery as compared to the laser. You understand it? So I hope I have cleared all the queries in the minds of the newcomers regarding the holmium, thulium, and thulium fiber lasers. Thank you.
Sir, can I ask a question, sir?
Yes, yes.
Yeah, this is on behalf of so many residents. So if I correctly understand, comparing TFL, thulium YAG, and the holmium laser, because of the micro bubble nature, the best dissecting laser is holmium. Am I correct, sir?
Yes, yes.
It dissects. And if we talk about the coagulative property, the best coagulating or a sealing laser is to be thulium YAG laser. Correct, sir?
Yes.
Correct. Okay. So that is what I understand. So please correct me if
because
I'm
thulium
wrong.
YAG laser and thulium fiber are cutting lasers, whereas holmium laser is a dissecting laser. But the hemostatic properties of thulium YAG are the best. These are, I have a strong disclaimer. In long-term scenarios, all the lasers and all the energy modalities will create the same kind of outcome. There are no arguments which have proven any superiority of any laser with the others. But this is the theoretical discussion regarding the properties of the laser energy. That is a strong disclaimer that I want to
correct. So if we go by that property, Ketan sir, what we understand is that if given a choice of a patient who has having a bleeding tendency or who is on antiplatelet agents on any day, rather than holmium, either thulium YAG or TFL laser would be a better kind of energy. Correct.
Thulium YAG is the best in hemostatic problem.
Best thing. Okay. Thank you, sir.
Thank you.
Yeah, I have one question on this laser. Like you have mentioned the absorption of laser in water.
Yes.
But how these three lasers are differentiated in respect to the absorption in hemoglobin?
No, the thulium YAG laser is best absorbed in water as well as hemoglobin in blood. Whereas thulium fiber laser is poorly absorbed in blood. That's why the hemostatic properties of thulium fiber laser are poorer as compared to thulium YAG laser.
Yeah, and holmium is absorbed.
Holmium is mainly absorbed in water. So that is why it is not so good in hemostatic properties.
So Ketan, thank you very much. That was a very nice and elaborate presentation, including the comparison of the physics of the three types of the laser which most people are using.
Thank you, sir.
And we'll keep some more discussion for comparison after Dr. Sadashiv Bhole has completed his turn on the HoLEP. So
Sure.
can I invite Dr. Sadashiv Bhole now to share his presentation on HoLEP? He is an eminent urologist from Nagpur, a very active member of Rezūm, and has very great passion for endourology, stone diseases, and has also been quite active in the front of laparoscopy and robotic. Dr. Sadashiv Bhole.
Give me 1 second, sir.
Take your own time. Any more questions meanwhile for Dr. Ketan Vartak?
Give me 1 minute, 1 minute.
Yeah, take your own time, Sadashiv sir.
Sada, by the time Sada gets through with the technical gauge, Ketan sir, let me take advantage of this particular time. So, given a choice, which is more charring laser? Is it the TFL or the Thulium YAG, sir?
See, if you see the capsule at the end of the enucleation, the Thulium YAG laser will have a lot of charring seen.
Okay.
But if you see the depth of penetration, that charring is hardly 0.2 millimeter in depth. So if you just move your fiber across, then the charring will go.
Okay.
And whenever I have staged my morcellation to say a day or two later, that charring is hardly there. So it is just washed out. It is just the apparent thing. It is
so
not.
We'll get this discussion a bit further after the HoLEP and enucleation been discussed. Okay. So Sadashiv, are you ready? We could see your slides.
Yeah.
So why don't we start? Thank you.
Yes, sure. Can you hear me?
Yeah, we can hear you.
Okay. So I'll just start my presentation. Thank you, everyone. Thank you, Rezūm, for giving me this opportunity. We will be talking about holmium laser enucleation in prostate. As Ketan might have covered this, it is basically light amplification by stimulated emission of radiation. It was the foundation of this particular work was led by Einstein. Now, in 1963, Ruby became the first laser to be used in the eye care. Basically, the laser device has three components. One is an active medium or lasing medium. Second is an optical cavity or resonator. And third is an energizing source or...
Sadashiv, your slides are not moving and you are not on full screen.
Yeah, you go to slideshow.
Oh, sorry. I've from my side, I've done it. 1 second. Are you seeing my slides now?
No.
Share it again, Sada.
So you click
okay, I'll
start slide sharing and possibly start the play.
Yeah.
Stop sharing again. Exit.
So the first share and then make it full screen.
Yeah. Can you see my presentation now?
Not yet.
Not yet.
Close your presentation, sir. Again, open it and share it, sir.
Yeah. So I'll again go. I'll again share. Can you see that now?
Make it full screen now. Yeah, perfect.
Can you see the presentation?
So we can see a presentation.
You can see the presentation, but it's
Exactly.
not full screen.
Yes.
It's not a slideshow.
Can you see it now? Okay.
Last slide. You're on last slide.
You're on last slide. Slide number 1 and then go to the slideshow, sir. Go to slide number 1, the first slide. Drag it all the way up. Correct. Now, bottom.
Slide.
Yeah, so bottom right.
Use the button.
Bottom right.
1 second.
Use the button.
This is my first.
Meanwhile, there were two questions.
This is my first slide. Can you see?
Kirpekar, sir.
Yes.
By the time Sadashiv is ready with his presentation, there were two questions. One was from Dr. Prashant Mulhavkar to Kirpekar, sir, where he says whether the TURP has started before antibiotic era, because it was Alexander Fleming who started penicillin in around 1950s. So where the prostate resection started before that?
Yes, prostate resection started in 1940, to be very precise. That's the birth of TURP. But then it took 20 years of evolution, improvisation, before it became a standard of care in 1960. So hopefully, I presume the antibiotics came in 1950, and that stabilized the procedure much more, making it acceptable and coming to a stage of standard of care.
Yeah, great. Sadashiv is on. So let us.
Right lower
give it to
button,
him.
sir. So the right lower button. Right lower button, sir.
Right lower button. There's more there.
Here.
Just to the left of the minus sign, sir. Zoom. Yes, sir.
Come down. Come down. Next to the minus side.
Next to the minus sign, sir.
No, on the right, near the volume button. Near the volume button.
Yeah. You are reaching there.
No, almost there.
No,
I
you're
don't
going
know
away.
what's
You're going away.
happening. Acha.
Little more, little more.
This is
For Sada, HoLEP is easier than slideshow.
I know what.
He's
Really.
an action man.
Now I got it. Yeah.
And one more
Can you see my
introduction which
presentation
Subodh
now?
had failed.
Sada, you
Sadashiv
can
is
move. Sada, you can move from this, no problem, sir. You can move, drag, next slide, next slide. You go like that. There is no problem. Or else, sir, let us take Abhay Mahajan's talk next, and we will coordinate with Sada.
Yeah,
Fine.
give me
We can do that.
Please. Sir, please.
Is that
do
okay?
Yeah, sir.
I will
please.
just
So
disconnect and again I'll connect. There's
Yeah,
something.
no problem. So let me invite Dr. Abhay Mahajan, who's a professor of urology in Aurangabad Medical College, a very prominent urologist from the city who has special interest in endourology, lots of publications, and who regularly holds and conducts courses for endourology for trainees. He is going to speak on the next topic. So, yeah. Okay. So, Abhay, can you share your slides now?
Yeah, I think you can see my slides.
Yeah, we can.
Before Abhay starts, I will
doing
add
his
one more important point in his introduction. Abhay has really defied age. He looks the same from his training till today.
Thank you very much.
No, what is the connection between this and BPH?
That I think.
No worries. But I agree with him. Okay. Please start your speak.
Thank you. I think you can see my first slide. Hello.
Yes, we can.
Yes.
I can hear you well.
Yeah, thank you. Thank you, Rezūm. Thank you, all the council members of Rezūm. Thank you, Vilas, for giving me this opportunity to speak on thulium fiber laser enucleation of prostate, usually known as ThuLEP. I have no disclosures. So initially, as you all know, laser prostatectomy started with holmium laser because the absorption was around 0.4 millimeter. It nicely used to cut, coagulate, ablate, and enucleate the tissues, and was considered the gold standard for tissue enucleation. But there were some limitations of holmium laser, like the wavelength did not match with water absorption of the tissue. And this was the major advantage of thulium fiber laser, where the wavelength of 1940 exactly matches the water absorption of the tissue. The thermal damage zone is quite high in holmium laser, around 400 micron meter. The thermal damage zone in thulium fiber laser is very low, around 100. There is more scarring with holmium laser, and there are in vitro studies which have proved that there is significantly less scarring with thulium fiber laser. And it is in pulse mode, where thulium fiber laser is available in both the modes. Ketan has already shown us all the details of all the lasers. If you see the beam of holmium, it is much scattered laser beam, but the thulium fiber laser beam is precise and a focused beam. So the holmium laser, because of the scattered beam, creates a very irregular coagulation zone, where if you see the thulium fiber laser, there is a much defined thermal coagulation zone in the tissues of 400 micron meter. And because of this, thulium fiber laser is in many studies and many urologists, they considered it as a better laser for prostate because the absorption is less. It cuts, coagulates, ablates, and enucleates the tissue nicely. It has got a very precise incision and coagulation zone, and it is entirely different from the Thulium YAG laser. So initially there were studies when the laser was invented. So you always compare with the standard available procedure, that is the transurethral resection of prostate. And this was the study which showed that the surgery time though was more with ThuLEP as compared to TURP. The catheterization time was significantly less. The hemoglobin drop was significantly less. And the PSA decrease was significantly more with ThuLEP, suggesting that the amount of tissue which is removed by thulium fiber laser is much, much better as compared to TURP. This was the study which compared larger glands with open prostatectomy, again a standard procedure. Obviously, the catheterization time with open surgery will be more as compared to an endourological surgery like ThuLEP. The hospital stay was also more. The hemoglobin drop was more with open surgery, and the blood transfusion rates were more. So thulium fiber laser again scored better for large glands if you compare with open prostatectomy. This was a study which compared HoLEP, ThuLEP, and monopolar enucleation, and they concluded that there was no significant difference between the complication rate. All the complications were very, very minimal, and prostate volume and patient's age did not affect the complication rate. So all these are safe, can be safely performed. There was no disadvantage as such with the thulium fiber laser if you compare with the standard holmium laser. Now, I do thulium fiber laser enucleation of prostate usually by an arm block technique, and this is a small video or a graphical video which shows how it is done. The right and the left lobe is entirely enucleated as one single lobe, which is then pushed into the or dropped into the bladder and then morcellated. So it's only one lobe which is enucleated. I don't do a 2-lobe or a 3-lobe technique where right lobe, left lobe, and median lobe is resected, enucleated separately. So a single lobe is enucleated. So just a small video where of thulium fiber laser arm block enucleation of prostate. This is around 80 grams prostate with right and the left lateral lobes enlarged. There's a small median lobe you can see in the center. The bladder was normal. So before I start the procedure, usually I start with the left apical lobe and enucleate the left apical lobe till I reach the capsule. So once the plane is reached and the capsule is reached, then you move on the other side. This is the laser setting, but now I have changed the laser setting to 2 joules and 46 hertz, total of 55 watts. I use the full potential of the machine. I have a 60-watt thulium fiber laser. And once the left lobe is done, then the right apical incision is taken. Both the apical lobes are enucleated, and then an early apical mucosal release incision is taken. Now, this incision is very, very important because this disconnects the prostatic lobe with the sphincter mucosa. So once you take this incision and start enucleating, there is significantly less traction on the sphincter because the mucosa gets disconnected from the area of the sphincter which lies just away from the just distal to the apical lobe. So once that mucosal release incision is taken, then both the incisions are then connected right in front of the verumontanum. And this incision is now deepened from 5 to 7 o'clock position so that the base of the prostate is completely lifted up. You can see the excellent coagulation which occurs with thulium fiber laser. The bleeding is significantly less as compared to holmium. I also use a 100-watt holmium machine and I also do HoLEPs, but the bleeding is significantly less with ThuLEP. Now this is the roof dissection at 12 o'clock position. Once you come near the bladder neck, you can see vertical fibers. The bladder is then opened from outside in, and the bladder neck incision is then deepened on the lateral aspect. So the base was completely lifted. The roof is now open at the bladder, and along the capsule, you just keep on going down on both the sides to enucleate the lateral lobes. So the left lateral lobe is then enucleated from the roof from 12 to 2 o'clock position. Similar procedure is repeated on the other side. You can see the capsular fiber, the white fibers which appear right in front of it. The only difference between HoLEP and Thulium fiber laser is because of a little bit of charring effect, the tissue blanching is significantly more with Thulium fiber laser, which is not there with HoLEP laser. So the appearance of the capsule is totally different as compared to the HoLEP laser in Thulium fiber laser. So once this is done, both the lobes are enucleated and only the bladder neck is remaining slightly on the left side. You disconnect that and one single lobe is then enucleated in the bladder and a standard morcellation is performed. Once you do this, you inspect the orifices because you're coming from outside in, you have to be right at the bladder neck. The only problem is if you're not correct in the correct plane, you can go very near to the ureteric orifices and you can see the intact sphincter here, where if it is intact, the chances of incontinence are less. So why arm block ThuLEP is preferred over 2-lobe or a 3-lobe technique? This was the first presentation which was done by Fernando Sancha, who actually propagated this technique or procedure of arm block enucleation. Subsequent, there were many studies by different authors which they proposed arm block technique, saying that it is very safe, feasible, extremely effective, and the complication rates are almost equal. It also significantly improves the enucleation time and the efficiency. And a few authors also say that a laser neurosurgeon can easily acquire this technology. So this was the study. These were 2 studies which I was one of the author of the global study, which we contributed a huge number of patients to compare between arm block and non-arm block technique. And we concluded that the complication rates with arm block technique are lower. The operative time is significantly less. It also reduces the stress urinary incontinence, and the urge incontinence is equal in both the procedure. This was a study which we published when we compare the standard 2-lobe technique with the arm block technique, and the same graphical representation, the procedure which I showed was published in the Urology Research Practice Journal, formerly the Turkish Association of Urology Journal. And we also had the similar results of less enucleation and operative time, significantly less stress urinary incontinence as compared to the 2-lobe technique, and better quality of life score with the arm block technique. So with our early experience, the precision of incision is very, very precise with the Thulium fiber laser. The coagulation is extremely effective. There is less bleeding, and the effectivity is same as TURP and HoLEP. Thank you very much.
Abhay,
yeah,
what Ketan was talking about is the Thulium YAG has a better coagulating ability as compared to the Thulium fiber laser. But in your resection, I hardly saw a red color anywhere. It was absolutely clean. How
yes,
come did you achieve such a fantastic hemostasis?
Sir, I have no experience with Thulium YAG laser, but I also do HoLEP with 100 watts routinely, sir, at a medical college. But I find there is significantly less bleeding with Thulium fiber laser. Maybe it has got a very good coagulating property with the tissue coagulation zone which is extremely in a more depth as compared to HoLEP. And secondly, so nowadays we do all the ThuLEP with aspirin, continuing the aspirin. We don't stop aspirin of any patient, we only stop clopidogrel. And in spite of continuing aspirin, we have found no bleeding with all the patients who undergo ThuLEP.
Good job, good job.
Abhay sir, I have one question and one comment. Yeah.
Yes.
Sir, please. You have said that stress urinary incontinence is less in a end block technique compared to the 2-lobe. So what is the reason behind this?
The reason is because of the early mucosal release incisions. So once you release the mucosa from the lateral lobe at the end of the apical lobe, which is just adjacent to the sphincter, when you start enucleation, once you take the mucosal apical release incision and start enucleation, the traction on the sphincter is significantly less. Actually, it is not bit en bloc, but there are reports or
that can be done
literature
in bilobar
that
also.
can be done in TULEP technique also. But if you do an early mucosal release incision, the chances of stress urinary incontinence are significantly less.
Yeah, one comment here. When we do two lobe enucleation, second lobe is generally half of the time of the first lobe because you got a lot of maneuvering space and the
Yeah.
fossa is open, the flow is good. So once you take like 30 minutes for one lobe, second lobe happens in just 15 minutes or less than that time.
Yeah,
So
but
that
that
is
is
the
only for small and moderate gland. But if it is a large gland, what happens is usually we tend to do the right patient's left lobe first, which is easy for a right-handed surgeon. And then for large gland, when you go on the right lobe of the patient, it is very difficult to maneuver your resector scope to enucleate. So in large glands, actually, you feel that there is a lot of space, but it might sometimes require more time to enucleate the right lobe of the prostate, because a right-handed surgeon to enucleate the right lobe is slightly difficult when you have to move all around from the base to the apex. And
what
the
do you suggest for the newcomer? Like after how many cases he should start en bloc rather than the two block? Because for the beginning, it is always suggested two block.
Abhay, before you start answering, Sada, can you start sharing your slides so that by the time we get the answer, we can sort out your problem. All over to you, Abhay.
Yeah, that's right.
I will do that.
So
Yeah.
after how many cases you suggest en bloc? Like
Yeah,
for a
I think-
newcomer, like a new one.
Yeah, yes. I think after 25 to 30 cases, you can easily start doing en bloc technique. The only point of concern here is you should be able to identify the capsule and the lobe. The differentiating point is once you start identifying the capsule nicely, you can easily shift to an en bloc technique. It is a very simple technique. It is not at all difficult. If you remain towards the prostate gland and if you don't go towards the capsule, then the chances of subtrigonal perforation, chances of going deep into the capsule are very low, and you don't damage the ureteric orifices of the bladder neck.
So I think we'll have some more time, and meanwhile, Dr. Sadashiv Bhole is ready, so we should get his talk now up and about running. Sadashiv, are you ready?
Give me a minute. Sada, drag your arrow downmost right side bottom, please. You see 66% on the bottom right, sir.
Bottom right, no?
Drag your arrow to 66%. Still right side.
Wine glass sign.
I can't see it on my computer.
Right
That is
side
what
of your screen.
Wine glass sign, there's no wine glass sign.
Go to the volume and come to the
Just
right
left
of the
volume bar.
Sada, press from beginning, no? From current slide, from beginning.
Yeah, I did that. Can you see that now?
Click
Can
on
you
the
see it
first
fully
one.
now?
Yeah.
Can you see it?
Is not
No, sir,
Go to
no,
the
sir.
volume, plus minus, and stay next to the minus.
Sada, see, that's not confused. Do you have your power to drag your arrow? Yes or no?
Yes, yes.
Yeah, so can you just scroll the arrow for us? We can see that.
Can you see this more?
No, we can't see the arrow.
This is the arrow. Can you see the arrow now?
Yeah, I can see. Now you just
drag it down.
One person at a time.
Yes.
You go down. Right. Just left. Go slowly on the left. Still left. Don't touch that. Still left. Don't touch that. No. Next button. That's it.
You got it?
The wine glass.
Bang on.
Click
Should
it.
I start now?
Click it.
Click.
The arrow is gone away.
The wine glass. Now you see what is wine glass. No, you just click that and make it full screen, sir.
Enlarge the.
Now what has happened? Sadashiv, one sec. You have made the zoom to 120% to reduce that.
Yeah.
No.
Reduce that.
Nothing.
Reduce. Left side.
Reduce.
Opposite. Yes.
Okay.
Perfect.
Anytime what you comfortable, koi dikkat nahi. I'm whole day in the hospital only. Only thing is I'm in the surgery in the morning from 9.
Rajesh, mute yourself. Thank you. Yeah, now make it full screen again. The same button, sir.
No, it is not happening. Can you see the slides like this? Can I just go?
Yeah. You can drag
most of the things are already covered. And,
one more thing, you can send the presentation to any one of us, and then he can play on it.
You click like that. No, now what you are doing, you can present like that.
Correct. Over to you. Correct.
Right? Can you see now? See some
Yeah, we
of it?
can see. You can
Yeah.
start
Yeah.
now.
Okay. So we have had a lot of discussion on the technical part of it. HoLEP has also been discussed. Now, any basic laser devices got three components. That's what we were discussing, right? And holmium laser is a laser whose active medium is yttrium, actually, aluminum. It is doped with holmium. It has got a wavelength of 2100. Now, one of the greatest capability of this particular generator is that it can deliver up to 350 microsecond pulse duration. The pulse duration is really short. So the massive pulse frequency can be generated at the tip. The laser is absorbed in about 0.5 millimeter of fluid and making it an ideal laser, because even if the depth of penetration is less, it is better. Laser energy is device basically delivered to the surface using quartz fibers. We have different fibers. Usually 550, 500 micron fiber is the one which is used for holmium for enucleation of the prostate. Transurethral resection has stood the test of time, and but it has certain disadvantages, particularly the bleeding. Everybody agrees that bleeding with TURP is more monopolar, much more. There are chances of clot retention. TURP syndrome is very rare now, but it is one of the possibilities. And the most important point is that it has got limitations as far as the size of the gland is concerned. Over a period of time, as surgeons have improved their endourological skills, still there is always one cutoff where one would say that TURP is to be not preferred as compared to the laser enucleation of prostate. Now, holmium laser enucleation, the originally work done by Gilling et al. From New Zealand was amazing. And one of the advantages which we saw was that it was absolutely hemostatic. Now, there was a discussion about the thulium and thulium fiber laser and their capability to coagulate. But yes, they have better capabilities of coagulation, but holmium charges much more less. So the tissue thermal trauma by HoLEP is more. Having said that, if you have two comparable cases where one has been done using a thulium laser or thulium fiber laser and other as a holmium laser, you will find that the hemostasis may be a bit of a problem in holmium. But the amazing pulse rate that it generates while dissecting the adenoma away from the capsule gives it a lot of advantage over continuous firing lasers, particularly thulium laser. Now, the disadvantages are increased time of resection or enucleation, which is actually relative. Now, we take less time to enucleate than to operate a same kind of gland, provided the gland size is more than 120 grams. The initial cost is a problem. And yes, there is a learning curve. So was it that we were driven by industry, or we were driven by our way to change the prostate? No, but there were multiple studies which have documented safety and durability of enucleation of prostate, particularly laser enucleation of prostate. Most of the urologists trying to study this technique or master this technique get lost in the dissection and basic planes of surgical planes between the capsule and the adenoma. However, we see that with holmium particularly, about 10 to 15 properly mentored procedures are adequate for achieving a confidence to operate their own patient separately. The equipment which I have been using is a 50-watt laser source. And I went along demonstrating that 50 watts is as good as a 100-watt or 120-watt holmium source at that particular point of time, because there was just a belief that it is much more slower and it won't be able to enucleate glands. The standard continuous flow resectoscope is used with a modified working element for laser. I usually use a 500 micron fiber. I'll tell you that there is also a 600 micron fiber available for holmium use. And of course, we need a tissue morcellator at the end of it. This is the Origa Excel machine which I was using. I still use it, but now I have the luxury of having 2-3 laser sources. So thulium fiber laser also we use. Tissue morcellator, I use the Wolf morcellator. And let's talk about technique, because Abhay was talking about on-block technique. Now, basically, it depends on the level of expertise you have achieved and the level of training one has, and also the technical difficulty of the gland. Now, there can be on-lobe, there can be 2 lobes, there can be 3 lobes. Usually, if the median lobe is large, then a 3-lobe technique is much more easy to do. In a small median lobe or a moderate sized gland, a two-lobe technique is preferable. One lobe technique for beginners particularly and for residents who want to know about it, three lobe technique or two lobe technique are easy to learn first when we are learning the art of enucleation. The on block technique, I still believe, is a procedure which can be attended only when one has achieved mastery in this technique. So the technique videos I'm not putting here because we have so many videos which we can see. This is the basic technique of the dissection. And more importantly is the dissection at 12 o'clock position, because that is the place where it is technically difficult to do. It is important that we have good bearings of the verumontanum. And you all know by enucleation, we have known that verumontanum is just a landmark, because many times the lobes extend far beyond the verumontanum. And this is important particularly in us where we are enucleating. In resection, this might be a very important point, but this is very important when we are enucleating, because otherwise the lobes will not enucleate and we may go into a wrong plane. So one lobe technique is technically more complex, as I told you. One of the advantages is saving of time. But if whatever is safe when you are learning this procedure should be attempted. There is a separate hemostasis unit in the Holmium which I am using, where the setting has to be changed. Now TFL lasers have got a pad like a cautery pad where we can use. Now, one of the great advantages of laser enucleation or use of TFL or Holmium or Thulium is the use of less caliber instruments. So we are able to achieve this enucleation at a caliber, at a much less caliber. 22 French resectoscope is also adequate. Once this is done, then the immediate post-op care is usually simple in all any technique of enucleation that one does. So in a nutshell, HoLEP offers a clear advantages that we all know. It is not only HoLEP, it is all type of enucleation using lasers is a better kind of a technique for reducing catheter times, hospitalization and blood loss. So there was one thing which we are always debating is only the 100-watt laser in Holmium necessary? No. If there is a good machine which is generating even 50 to 60 watt, that is adequate for a good enucleation. Basically, these 50-watt lasers are very simple. They are easy to maintain and they don't break down easily. So we had a 50 watt since 2012, and this is a data of the first 200 cases, and we were very happy. So sometimes we need to combine, as Abe was saying, that they don't stop aspirin. Now we have certain very high risk cardiac patients where they are put from anticoagulants onto low molecular weight heparin. So one can use laser enucleate it and also use a bipolar button cautery or a TUR loop for better hemostasis, because I think in my kind of practice, safety is much more important in the technique, and all it needs is just to basically change a working element. So apical tissue can also be sometimes in the initial period, we can use a little bit there when we are learning. So what are the worries and concerns? One of the greatest worries and concerns, however, whatever we are claiming in enucleation, it is my personal opinion and there are many people who share it, is the worry of continence. So the worry of continence in a person who is doing a TURP is much less, and it is much more in any kind of enucleation, I would say. And also sometimes a narrow urethral caliber can be a challenge. So there comes the role of slim HoLEP, because whatever the size of a outer sheath of the resectoscope, if you can get irrigation and laser fiber up to that tissue level, it is possible to morcellate. So we come to the basic, the fundamental question: why enucleate? Why do all this? Because ultimately it's a more durable procedure. It gives better flow rates, durability, and also it is safer in comorbid conditions where anticoagulants are. So I'll not talk much about laser. These are some of the references of use of 30 to 40 watt of laser in enucleation. So the learning curve is one thing which has to be overcome, and it is something which you actually puts off many people who start doing enucleation. So one of the things is proper selection of cases. The cases should be moderate glands, not very difficult. Mentoring should be there, equipment should be good, and ultimately safety is the last thing. And prudent approach to any resection is possible, is required. Thank you so much for your time. Thank you. Hello.
Thank you, Subodh. And Sadashiv, thank you.
So, Vilas, can you invite Anand and Rohit subsequently for giving their talks? And if any time left, we'll have the discussion at the end, as I'm getting a
Yeah,
message from the administrator that the time's running short.
yeah.
Thank you. Thank
So
you.
we'll invite
Rohit.
Dr. Rohit, again, young active urologist from Ahmedabad and well known to all of us. He has a huge amount of work, more than 5,000 cases related to holmium laser, endourological cases, holmium enucleation, then RIRS, and mini works. So over to Rohit.
Yeah. Thank you so much,
He's
sir.
going to
Are
talk on
my slides?
urology.
Yes, sir. The slides visible to you, sir?
Yes.
Yeah,
Yeah,
I'll make
very
it full.
much.
Yeah. I'll make it full screen, sir. Good to go, sir.
I think you're
Absolutely.
good to go, Rohit.
Yeah,
We can see your slides. Thank you.
Thank you so much, sir. At the outset, let me thank the Rezūm USI Council and the conveners, Vilas sir, Subodh sir, Pankaj Maheshwari sir, and Ajay Bhandarkar sir for this kind opportunity. Uh, Friends, I don't think we are merely doctors or surgeons. I consider ourselves as scientists. May not be we are research scientists, but we are actually clinical scientists. So whenever there is a necessity, we do invent, we come across some limitations, we improvise, and then ultimately we innovate. So the same evolution happened in surgical management of BPH. It started with open prostatectomy. Subsequently, it was replaced by TURP. Then there was some limitation, so we ended up having endoscopic enucleation of prostate. So friends, result-wise, if we say, the results were fantastic to say the least. This was the kind of fossa which one can have after a good enucleation or a very good resection. And this is kind of superflow to the tune of 52 ml per second, which we can get after a good HoLEP or a good TURP. But friend, it came at certain cost. Now this cost is like what a urologist wants is a very good flow. Kirpekar sir, can we mute ourselves? Thank you, sir. Yeah, so this is what a urologist wants, but not at this cost. Even if our patient comes in OPD and if they can have dripping little bit, it bothers us a lot. And what our patient wants is a very good flow, but not at this cost at all. So these are the two primary concerns for a urologist and the patient. But more importantly, neither of them wants to see this at all, which is a dreadsome complication in form of a urethral stricture, because as we all know, once a stricture, always a stricture. So these are the most serious concerns with the TURP and HoLEP. And friend, that is why evolution continued, and that's how MIST came into the practice. Now, what does the MIST offer? They offer a reasonable, let us be very realistic, but not a very superfluous improvement in LUTS and UFM. There is no undesirable impact on either continence or ejaculatory function. And it is an excellent recovery and quality of life, both for the patient as well as for the urologist. And most importantly, it is considered to be a urethra sparing or urethra preserving approach, because whatever sheath size we are using is 17 to 19 French. And the time of operation is very less. Friends, why do we talk about MIST for BPH? Because I believe we all need to understand that BPH is not just about LUTS. BPH is not all about LUTS. And BPH is not LUTS. There are a lot of things beyond LUTS when a patient walks in with BPH. There are so many other parameters to look at. So, friend, that is why we need to discuss about MIST for BPH. Now, there are two categories. One is tissue ablating and one is tissue sparing. Out of these, four of them are currently available, except equiablation. All the rest of three have been launched commercially. Equiablation trials are going on at Nadia. Very soon, we'll have a commercial launch. Today, I'll be restricting myself to talk about prosthetic urethral lift, that is a UroLift. Now, what is this UroLift? It's a mechanical solution for a mechanical problem, a very logical one. Now, these are different segments into which I'll bifurcate the talk about the UroLift. Yes, it was first described in 2010. Subsequently, it got approved in TG in Australia. Then US FDA approved it in 2013. In UK, it got incorporated in NICE in 2014. It was introduced in India a decade later, that is 2022 November. And now we are probably 2.5 years of experience. Now, the concept basically is to create an anterior channel. If we can, configure the prosthetic fossa with a wall clock, what we are intending is to create an anterior channel. We are not doing anything in the posterior channel because important blood vessels and neural structures are there. Now, there are two kinds of mechanism. One is the immediate, which is a mechanical separation, which can be achieved by placing a set of implants on each lobe. And this is what we get immediately after taking the implants. However, one can argue that this is only a temporary effect, but no. There are certain histological artifacts and remodeling happening, which was proven in the MRI that even after the placement of implant, the prostate keeps on growing. It follows the curve which is created by this implant. So there are dual mechanisms. Now, these are the standard indication for all patients where they need surgical intervention. We can offer them UroLift. More relevant is to understand what are the contraindications. Now, these are the absolute contraindications, like in patients with active UTI, any urethral pathology like stricture, any remote suspicion of carcinoma prostate, because we're not getting any tissue, either with Rezūm or UroLift, we're not getting any tissue. So even there is a remote suspicion by an abnormal DRE, elevated PSA, something abnormal on TRUS, we need to rule out CA prostate by very aggressive approach. Lastly, we should resort our UroLift only for prostatic volume less than 80 or 100 ml. These are relative contraindication, but with the next generation implants, we are now been able to take up these patients as well. And this is the armamentarium. To the left of your screen, we have the standard set of cystoscopic instrument, 20 French sheath, breech, and a 4 mm scope. On the right side, there is a urolative assembly, which has got a 19 French sheath. There is a dedicated breech, and there is an extra long, slender 2.9 millimeter scope. And lastly, we need to have the implant. Now, this implant is a disposable one. It's a use and throw. It is kind of, a biomedical waste issue. But now with the second generation, we are reducing that biomedical waste. We'll talk about it sometimes later. Now, this is the device. We need to identify the device and we need to know this device in detail, because there are so many buttons and it can be quite confusing if you don't know it properly. There are several buttons. So whenever we adopt this in patients, before that, we should have a neck of this device and know each button in detail. Now, this is the implant. There are three components of implant. The one is urethral component, which is made up of stainless steel, 8 millimeter in length. Then we have a prostatic component, which is 13 millimeter long, which is made up of nitinol. And there is an adjoining suture between that, which is of PET. That is what is responsible for mechanically tracking out the prostatic lobes. This is a small clip of animated clip of how the UroLift has been done. So it's a standard cystoscopy done. And first of all, we go to the bladder neck and then we ascertain the prostatic urethral length. We need to recede at least 1.5 centimeter away from the bladder neck and put the first set of implant. And then if the urethral length is more than 3 to 4 centimeter, we can still further recede 1.5 centimeter, staying at least a centimeter away from Veru, and can have a second set of implants. So this is what we get immediately after the placement of implant. A very good channel created there. If we can look at the clinical thing, the same thing which has been done. Once again, you just compare the entire rounded fossa to the wall clock, and we always tend to remain beyond 3 o'clock and 9 o'clock. So this is the patient's left lobe side implant, which has been tagged at 3 o'clock. And now I am taking the implant on the right lobe of the patient, which is at the 9 o'clock and 10 o'clock. So after placement of these two implants, hardly a question of 5-7 minutes, and this is the immediate effect which we get. So we can actually create what we are seeing in the animated film. This is the effect which is created by the placement of implants. Friends, the results are very good. There is significant improvement in IPSS and LUTS. There is no de novo side effects on the erectile dysfunction or ejaculatory dysfunction. No de novo incontinence. Quality of life and recovery is excellent. And these are the comparative results. One has to be very, very realistic. We are not going to get that big a fossa. What we are getting, it's an anterior channel. But even if, in the uroflowmetry, we are not going to get the super flow. What we are getting is a reasonable flow. You can see it is crossing 16 ml per second, which is very good, provided all the side effects are eliminated. So, friends, there are complications, but they're all minor. There are 99% of them are Clavin grade 1 in form of hematuria, infection, and retention, which are managed without any major intervention. There is plethora of evidence now. It has got more than 13 years of data available around the clock, 1,400 procedures in North America, with close to 3,000 procedures from UK, and many meta-analysis of 15 published studies. But this particular study is the one which actually is a landmark study. There were 80 patients across 10 centers in Europe, and it was carried out at a very stringent interval. And there were 6 BPH component assessed: LUTS, erectile function, ejaculatory function, incontinence, quality of recovery, and de novo complication. And to our surprise, TURP fared well only in one, that was LUTS component. In the rest, all 5 components, UroLift fared better than TURP. So, friend, time has come that we need to see BPH not just as a LUTS, but as a broad spectrum disorder. And that's why it has got a place in the AUA guidelines. It has got a place in USI guidelines of BPH. And if you could call about your advantages, there is no catheter. It can be done under local anesthesia, daycare procedure, no incontinence, ejaculation, rectal function are same as what they were before the surgery. Quality of recovery, excellent. There are few concerns. The improvement in LUTS, as I told, is not superfluous. It's suboptimal. Long-term data is now getting validated. The retreatment rate is quite high, 13.6%, and cost is a huge considering cost-sensitive country like India. But still, if I can give you a take-home message, friends, UroLift is the most physiological and most minimally invasive approach for BPH patient. Mind well, it's not a substitute of laser or TURP. You need to be extremely careful in selecting your patients. Only then you can get an optimal outcome. It can be offered to a moderate size of prostate between 30 to 80 gram. Make sure you don't have a significant median lobe enlargement. Active UTI and any suspicion of prostate cancer is an absolute contraindications. It is free from bothersome side effects of BPH medication. It's extremely patient-friendly compared to the TURP or HoLEPs. The downtime is very less. Patients can get back to their day-to-day routine in no time. So friends, when you walk back from this webinar and see your OPD or in your institutions, if you see any patients who are relatively young or sexually active, we can offer them as an alternative to medicines. Or in a very high-risk patients or patients who are not willing to undergo surgery because of side effects and complication, this procedure is worth revisiting once. Friends, I think I have given justice to whatsoever task been assigned to me, but I'm not here to tell that a particular procedure is better than B, because it depends on what you are good at, what your circumstances and what your patients are there. Because my friends, at the end, you need to remember, we only are the stone, we are the chisel, and we are the sculptor. For any questions, you can find me later also, or we can have the discussion at that. Thank you so much again for this opportunity. Best of you.
You were clear cut in your concepts. You just moved your 11 number slide very quickly, but that's where the crux is. Did you have opportunity to resect a UroLift patient that you had done before or somebody had done before?
Yes, sir. I did that, sir. I have enucleated 3 patients now. These 3 patients who had been done UroLift in US, and all of them were after 1 year follow-up. I did not encounter any problem in the enucleation, but there was a concern when I started morcellating. Once I morcellated the superficial tissue, once I came across a steel component of the urethra, and it broke my morcellator blade. So I need to be very careful subsequently. Yeah.
So what you're saying is absolutely correct. People who have had UroLift for a long time, they did very well. But when it came to resection, they recommend that bipolar resection is contraindicated simply because it causes a short circuit and a severe obturator kick. If at all you need to resect it, enucleation is fantastic. But if you want to resect it, then it has to be monopolar resection.
Correct, sir. Now, this 11 number slide, sir. You had something on this, sir.
No, you quickly summarize that. That's why, nothing else. Thank you.
I have one point to make. Yeah, Rohit, about the affordability of this technique. So, have you seen any case where the cashless facility is available for UroLift?
Sir, yeah, sir. HDFC, Ergo, Care Insurance, New India Insurance, all these companies are sanctioning cashless as well as reimbursement, sir. I have a data of now 42 patients. Out of them, 20 patients had cashless, and they all got either cashless or reimbursement. Yeah.
So 50% cashless is a good thing for newer therapy.
Yes, sir. Yes, sir. Yes, sir. But we got an approval.
So,
Vilas, sir, do you want to call in Dr. Dharaskar now and introduce him, please?
Yeah.
Meanwhile, I will open my slide. I will try to open it up here fast.
So Rohit was clear and precise. Now moving to Anand, another young dynamic urologist practicing in Pune, attached with Manipal Hospital. And he is graduated from SGPGI with excellent exposure on endourology as well as transplants. and now he is a Rezūm man for Pune and surroundings. Recently only he has done a workshop on Rezūm at KEM Hospital, Mumbai.
Can you see my slides?
Yeah, we do.
But it is not, I think, full screen.
No, it's not full screen yet.
So kindly press the play button.
Yeah.
Yeah,
Is it
that's
full
it.
screen? I am audible.
Perfect.
Yeah. So we'll start.
Perfect, sir. Yeah.
Yeah. So the last kid in the playground as of now is the Rezūm. So it is a part of minimal invasive surgical therapy for BPH. So we'll go to the basics of technique first. So the uniqueness of Rezūm here is a source of energy. As we know, all the tissue requires some kind of a source to remove the gland. So here the source is a heat, but it is not a dry heat. So there are a lot of initial concerns that it is equivalent to tuna. So the tuna is totally different, and this is a heat in the form of a water vapor. And second part is how you conduct the heat to the tissue. The conduction mechanism is not through the standard conduction, but is going through the convection. And it is targeted to the transitional zone of the prostate. So there are three very unique things about the Rezūm: is the source, then the convection mechanism, and second is the targeted therapy. So how this energy is delivered to the targeted therapy? It is in the form of a vapor, but the beauty lies in the concept of latent heat, which we have learned all in the physics. So water, when boiled to the 100°, it is still in the liquid form, but when it goes to 104, it turns into a vapor, and that latent heat is accumulated in the form of a vapor. And the moment this vapor is injected into the tissue, it converts into the water again, and during that process, the heat is delivered to the targeted area. So our agent of heat, the energy to the tissue is the latent heat. And how much is the heat? Is 540 per ml. And 0.4 is equal to almost 200 ml of calories per injection of the Rezūm therapy. So what happens to the 103 and 104° of vapor inside the body? This is immediately cooled down to a 37° of body temperature. The mean of this is going to be 70°. So the tissue around the injection is heated to the degree of 70° without any collateral damage in a uniform convective therapy, which goes all around the cell through the interstices. And this leads to the coagulative necrosis, blood vessels are obliterated, nerves are permanently closed, and there is a necrosis of the tissue. So 70° is achieved in a targeted manner. So one has to understand the difference between the conduction and convection. Convection is like spraying a perfume in a closed room. Everybody is uniformly getting the perfume, and conduction is like taking a swab from hand to hand, and then closer the source, more is the heat, and the away person will always get a less heat. So convection is the modality of heat transfer. And we are not targeting the peripheral zone at all. We are targeting the central zone and the transitional. The good part of Rezūm is median lobe and central zones are equally accessible to the therapy, as opposed to some other therapies where the compression devices may not be suitable for a median lobe. So how this concept eventually started? See, as a surgeon, we always love to see the things. Seeing is believing for most of the surgeon. So the Rezūm started in the initial lot of around 50 patients. They did all the patients subjected to Rezūm therapy, and then subsequently they were all subjected to the open prostatectomy, and the tissue was subjected to the histopathology. And in the second stage, they have done a MRI on all the patients of Rezūm. So in the Rezūm, and this is the ultrasound report where you can see the transitional zone is seen where the vapor is dissipated in the area of around 1 centimeter. So from the point of entry of vapor, all around this circumference, 1 centimeter will be the area of impact of that heat. This is the MRI picture. You can see that the gland is going smaller in size after a period of 3 months. So first phase was open surgery with histopathological evidence. In second stage, no open surgery, but only MRI was done. So thermal lesions over a period of time. So heat will never give a result within the next 2 or 3 weeks. The maximum period of time when the effect of heat on the tissue is noticed is at the 3 months, but which starts as early as 2 to 3 weeks and gradually escalated, and over a period of 3 months, you can find that the MRI is showing a shrunken prostate, specifically limited to the transitional zone. This is the endoscopic picture where you can see on the right side 3 injections were given and left side 4 injections and 2 were given to the median lobe. And this kind of a beautiful foci is seen after a minimum period of 3 months. So here you can see it is after 6 months. So it's a slow and steady procedure where the results are expected minimum at the level of 1 to 3 months. So this is the pivotal study. On that basis, the FDA approval was available for this Rezūm in 2015. What they have studied, compare this one group of patient with Rezūm to a sham therapy with a cystoscopy, rigid cystoscopy, and no more energy source use. Comparison done between the IPSS score and other symptoms that will come to know in the result section. What are the study protocol? Or well, 50 plus year patients. Gland size is the one important thing, is 30 to 80. So those who are inclined to start Rezūm, the first phase is going to be a standard 30 to 80 gram of gland. There has to be a proper obstructive symptoms to begin with, so that the appreciation of improvement is easily accepted by the patient. This is the 5-year data as of now available, and this is not any Indian data as of now. This is the only most durable data as of now available with the Rezūm. These are the authors who pioneered the technology, and on that basis only FDA approval was there. And the follow-up was up to 5 years. So we have as of now 5 years data on the Rezūm. So you can see the IPSS score has gone down from 22 to 10. That happens over a period of 1 to 3 months. So somebody is expecting results of Rezūm within the next 2 weeks or maybe around a month. Probably he is not the right candidate for Rezūm. One has to wait for the actual shrinkage of the transitional zone. Qmax from 9 has gone to 16. And this improvement in the urinary flow is maintained over a period of 4 to 5 years. Other bothersome symptoms score has also gone down, and these percentages around 48 to 50% improvement is all seen in all the categories. About the retrograde ejaculation and erectile dysfunction, de novo symptom occurring in any Rezūm patient is not found, and retrograde ejaculation is not seen at all. Almost you can say 1 or 2% of the patient can expect this, but you can guarantee antegrade ejaculation in up to 98% of the patient. These are the 5-year data of the patients. You can see at 5-year, treatment is a medical treatment and surgery is absolute interventional aspect, which goes up to 4.4% at the level of follow-up of 5 years. And for all other combined medical treatment like alpha blockers, anticholinergic, and antibiotics, these are 11%. So these results are fair results, and duration as of now is only 5. So as we go along, probably we'll soon get our data around 10 years, and Indian data is absolutely lacking as of now. So durability, you can say 4.4 is the retreatment rate at 5 years. So 95% patient will not get any other intervention. Improvement is always around 50% over the baseline, and that to maintain at the follow-up of 5 years, with no added disadvantage of erectile dysfunction, stricture, incontinence. These are absolutely 0. So safety profile is very much positive, and sexual functions are preserved. What about the median lobe? Whenever there are median lobes found in the study, all were treated. So nowhere there is additional treatment apart from Rezūm is given, and the results of improvement in the Qmax and LUTs are equally good with the median lobe. In fact, I found if there is a patient with a median lobe, one should always go with the Rezūm, and there is no absolute contraindication for that, because this shrinkage of median lobe is going to give early positive results, and the patient confidence is also established very soon. So I'm very much in favor of treating patient of median lobe with Rezūm therapy. So which are the patients where we can go for it? 30 to 80 is the standard gland what is required, and median lobe is not a contraindicated. One has to rule out CA prostate, and PSA and urine culture is must. Contraindication as of now, as per the initial study, is the penile prosthesis, active UTI, and the sphincter. UTI is not a important. Only thing is that you should identify it and treat it before going in. I have not got any opportunity to treat patient on sphincter or prosthesis as of now. So about the process. So it is a very portable kind of a device. The two parts are there. One is called a radio frequency generator, RF generator, and another is a disposable device. On the right of it, what you see is a disposable device. So company has created a disposable device as a recurring cost into it, and the left-sided instrument is a one-time capital investment for this. So how to go about the procedure? It is done through a device which is 16 French in size. So compared to other therapies, the tube is very small, and what we need is only telescope. Olympus telescopes are not suitable to the instrument, but rest is all Shawley, Wolf, and Stows are all compatible. What we need is only telescope and nothing else, camera and light source. So no more accessories from the endourology is required. So there are number of what is important in prostatic treatment is Rezūm is a prostatic urethral length. So there is a precise method to measure the length, and for every 2 centimeter there is going to be a 1 or 2 injections, because each injection will cater to a zone of around 1 centimeter. So as you go along from 2 to 3 centimeter, injection will be 2 to 3. More than 3, there will be minimum 3 injections on one side. Equally on the opposite side, plus if there is a median lobe, injection can be 1 or 2. And here the therapy cost is not changing as per the injection. Disposable device can accommodate 15 injections. And to my knowledge, I have not seen any paper where maximum 15 injections are exhausted. As far as I have seen, McQuarrie has used maximum 14 injections in one patient. More or less maximum number is 12. Personally, I have used 10 in my practice. So when you go inside the urinary passage, you have to measure the prostatic urethral length with the help of this instrument. The tip of the instrument and to the 6 o'clock of the screen is considered as a 0.5 centimeter or 5 millimeter. So always you have to measure 2 field of visions, and with that we can measure 1 centimeter of the prostatic urethral length. It may seem little difficult on the picture, but once you are inside, everybody is very well averse with the anatomy, and it is easy job. So there are basically 8 steps into it, and I will just show you how to prepare the instruments, and the injection part of it is actually very easy. And most important part is to identify the length of the urethra and to decide the number of injections. So once the machine is connected, this kind of a pre-treatment is there where you can do the same type of sequence of button compression, and the fumes can be seen outside the patient. So you are sure that the system is working and the temperature and the flow and other accessories are in place. So this is outside the body. Once you are inside, this putting the scope inside is as good as doing a cystoscopy, and the tube is very much smooth and elliptical in shape, and it is 16 French in the size, and the tip of the instrument is like a synthetic material, and it is atraumatic also. Once you are inside, most important is to identify the field of vision. That as per the instrument's design, it is always 5 millimeter, and number of field of vision will equal to the length of the urethra. And for 1 centimeter of urethra, there will be a 1 injection on the one side of the lobe. So here this image can show field of vision is 5 millimeter. So if you add 2 of them, it is going to be 1 centimeter. And once the field of vision is clear, this 18 gauge, this is a PTFE needle which comes out of the instrument, and it goes 1 centimeter inside the transitional zone. And when the needle is inside, if you press the another button, 9 seconds therapy will all be automatically delivered by the machine. There is no way that you can curtail it to any shorter duration. And after 9 seconds, you have to just withdraw the needle. So technically speaking, it's not at all a surgery, and it's a very simple cystoscopy and simpler injections into the transitional zone. So this is the diagrammatic description where number of injections are to be decided. There is a paper by McQuarrie who shows less is more. So if you are in a doubt that whether there are 2 or 3 injections required, always go with a less number of injection so that recovery of the patient is very smooth. And later on, you will always have another chance of putting injections inside. This is the picture of median lobe. So how the median lobe are treated differently than the lateral lobe. For lateral lobe, the needle goes exactly at 3 and 9 o'clock. So the instrument is parallel to the floor. So left or right perpendicular entry is there for a lateral lobe. And if there is a median lobe, this is going to be 45 degree. So one has to remember that lateral lobe is 90 degree and median lobe is a 45 degree. And the final assessment is to see whether you have reached the verumontanum. And the first injection is always 1 centimeter inside the bladder neck. So these are the steps of doing the procedure. I'm not showing any at length video. I'm giving the technical aspect of procedure. So what do we expect after the procedure? Depending upon the size of the gland, the catheter is removed after 3 to 4 days or maybe up to maximum 7 days. Larger the gland, more are the number of catheter days. After the removal of the catheter, patient is going to experience some kind of a dysuria. There is a one saying by McQuarrie, patients are going to hate you before they going to love you, because all will have some kind of a worsening of their storage symptoms. But it happens only in 3 to 5 days in initial period. That period you have to take care of your patients with good medication. And after that, their flow starts improving. And these are the references for that. We're about to conclude. There is one important concept introduced by Dean Elterman as of now. There's something called FIT, first intervention treatment. All patients, those who are on medicines, they are all not happy on the medicines and they are little bit worried about the surgical part like a TURP, HoLEP, or for that matter, any other open prostatectomy. To bridge the gap between the open surgery, the standard surgical options and medical options, there is something called first intervention treatment, and the UroLift and Rezūm are fitted into that, though they are far from ideal. But as of now, they are important gap between the medical part and the surgical part of the patients. So this is going to be a very good thing in the future, that first intervention treatment, one of them is going to be a Rezūm. Thank you for patient listening, and I'm open to questions.
Thank you very much, Anand. Any questions from the participating experts? Dr. Ajay, Dr. Pankaj?
Subodh, can I ask him a question? Rajesh here.
Sure. Rajesh, go ahead.
Yeah. Anand, if the patient is on retention, and is on a catheter,
yeah,
and after Rezūm, and you said that the treatment, the effect starts appearing after 1 month, then peak efficiency comes after 3 months. How long are you going to advise the patient to be on a catheter? Or when would you first remove the catheter?
it all depends upon the size. For 30 to 40 gram of gland, 3 to 5 days is enough. It like number of injections and gland size goes hand in hand. And if the gland size is 50 to 60, you will wait for 4 to 5 days. Gland size like 80 to 100, you will wait for around 7 to 8 days. In my practice, I have done 2 cases where the retention of urine was there and patient was absolutely unfit for any surgery. So anyway, they are on catheter. So you counsel them that you wait for 2 weeks of time and then you give one more trial. And if it is failed, you wait for 1 more week and then you will definitely get results. One such paper shows that 70% of patients on a catheter, so those who are unfit for any surgery, get successful trial without catheter. So 70% is a good number at the end of the day.
Thanks.
Vilas, do you want to get any concluding remarks?
We'll request our senior panelists. One thing I had not kept in the line was bipolar resection or bipolar enucleation. If the senior experts give some clue about it. Are there many centers who are still doing bipolar enucleation and vis-a-vis monopolar TURP and bipolar?
Yeah, you have Ajay sitting there. Ask his views.
Yeah.
I think we'll have to wind up this webinar. So quick comments for the overall surgical management. I think that we have realized in the last 3 or 4 decades that many procedures have come and you have stayed with us. So HoLEP is one of them because the enucleation is always better than the resection. That is what also we have realized. So, and I think any energy source for the good enucleation is good enough now because we all, those good enucleationists have developed their technique or realized the expertise. So any laser energy, there is hardly any 5-10% difference. The theoretical, like we discussed, that I think thulium YAG laser theoretically is much better because the water efficiency, absorption efficiency is 4 times than the holmium laser. Otherwise, I think thulium fiber, thulium YAG, all of them are equally good, and holmium also has its own advantage. The advantage of holmium is that we have more than 20-25 years of experience. And all these new procedures are also promising from the point of view that the perspectives are changing from the patient point of view. See, the patient may not like to become a super voider, but he would like to preserve the ejaculation. So he wants to get rid of LUTs. At the same time, he wants to have a sexual function preserved, and he doesn't want a medical management. So we should not be writing off the minimally invasive surgical treatment. So they have some role to play in few patients. It is our decision which patient is good enough, because of late I have realized, Pankaj will also agree with me, that many patients between the 40 and 60 years of age have come up with the LUTs, and very young patients like 45, 48, and significant obstruction, and they do not respond to alpha blockers. So we have to be very open and suggesting a right kind of a procedure to a right patient, and that should be the way to go. That ultimately patients are going to be the powerful decision maker than we, and we are the knowledge giver to them. That's it.
Can you
Pankaj?
Thank you, Vilas. Really nothing much to add. It has been a wonderful session. Undoubtedly, Kirpekar Sahab set the ball rolling by a fabulous description of TURP. Sir, in one of your slides, you had said that HoLEP has disappeared. If people can do TURP as good as you do, probably HoLEP will definitely disappear.
Yeah,
so,
I just commented on the slide that was produced by the global.
Even I saw that paper, and I really it was interesting for me to see that they have really not mentioned HoLEP in their list. I agree with Ajay that enucleation is enucleation, whatever energy source you use. It is important that we switch to enucleation from resection. Whether you do bipolar, holmium, thulium, TFL really makes no difference. But yes, whatever energy source you are using, you should be aware of the pros and cons of that energy source. Holmium laser is a brilliant dissecting tool. Thulium laser is a brilliant cutting tool, and TFL has advantages of both. But a major disadvantage that it will turn out to be a much slower procedure, so probably not the ideal laser for very large prostates. But for a run-of-the-mill prostate, whichever laser you use really makes no difference. Coming to the newer technologies which are showed by Rohit and Anand, surely a place is being generated for these technologies. If we really counsel the patient well, patients would be interested in maintaining their sexual function and ejaculatory function. And if they are so much keen on that, then these techniques can surely be offered. I really see a big place of Rezūm in patients who are extremely high risk, have been catheter dependent, and you want to get them rid of catheter. Probably this is one more place where Rezūm would work, probably much better than UroLift in these situations. But yes, I would just sign up by saying that I recently saw one extremely good, say, document on the Canadian Urology Association website, where they have come up with nearly an 8-page document which they give to the patient. Patient fills that document, and then based on the patient's responses, you can choose whichever is the best treatment for the patient. So time has come when we offer practically everything to our patient in something like a prostate care center, and then really give an individualized treatment to every patient. Overall, bright future for us, because with our increasing population, increasing age, increasing number of BPH patients, and increasing opportunities to treat, surely this is the way to go.
Thank you, Pankaj.
Thank you.
Amazing.
Thank you, Pankaj. Thank you, Ajay. Thank you, Kirpekar sir. Thank you, all the panelists, Rohit, Abhay, Ketan. Basically, the idea of Rezūm was to have exam going students and all the students prepared for this. And now the treatment part, they should, even the young urologists should be in a position to choose. And very soon, as Pankaj said, we'll have to have a menu-based treatment offered for prostate. So this was the idea, to have one single session to cover all these modalities. Thank you, everyone. Everyone has really done very nicely, and the message has got carried across to the young generation. And there was a question from someone, which laser one should buy from a young urologist. So I think they should be able to, if someone wants to talk something about it, they can, before we end.
Can we know how many attended this seminar? Roughly?
Around 40 to 60 people.
Lovely. Very nice. Good. Wonderful event. Good organization. Thank you, Vilas. Thank you, everybody, for doing it.
Vilas,
Thank you. Good night, sir.
One laser to be bought. I think right now, for many of us are doing a large number of RIRS, and one fit all laser will be the thulium fiber laser, because it has great advantages in fragmentation as well as dusting, as well as the prostate, and the cost is also less. So probably right now, one single laser, if you want to buy, I think TFL fits the bill.
Yeah, probably yes. And if somebody intends to do prostate, it will be 60 watt TFL, which would be a good bargain. And more important, 100 watt holmium laser had its own limitations as far as installation, and it is definitely a white elephant.
Because, the larger size, more than 80 gram prostate or 100 gram prostates are rare for a common urologist. So ideally speaking, our bread and butter is mainly the stone work. So if you put in the stone work, main focus on stone work, then TFL probably fits everything. And rarity, say, if it is 80 or 100 gram, then only the problem arises. Otherwise, TFL fits well for everything.
I would say that focus more on the technique, learning the right tech, which is more important. Which laser to buy, it is their own personal decision according to the finances available. Every laser has got its own advantage. And for the prostate, I think one has to focus on the right kind of technique, learning right way and practicing it right way. So every laser is good.
Sir, tomorrow never dies, sir. Let us call it a day.
Yeah.
Thank you.
Yeah.
Thank you very much.
Thank you. Thank you, everyone.
Before we
Bye-bye.
wind up, thank you, Abhijit, for coordinating
you. Bye-bye,
the
everyone.
audio visual,
Thank
the
you.
YouTube link, and thank you, Rezūm, for giving us the opportunity.
Lovely.
Thank you very much.
Thank you.
Rajesh, thank you very much.
Thank you, Subodh. Thank you,
Thank
Rezūm.
you, sir. And
Thank you.
on
Good
behalf
night.
of the council,
Let's
I
have
thank all the
more
faculty.
such enjoyable
I'm,
sessions.
I'm happy to see Rajesh at home, not in the car.
No, I reached home. Yeah.
So are you
Bye-bye.
saying Rajesh is bekar today?
He's just finished his huge work and just come home.
No, not as huge as yours, sir.